Vice Rounds is pleased to present Mikey Schaer's Medicine Case Rounds. For those of you who may not have the pleasure of knowing him, Dr. Schaer is a passionate practitioner and veterinary educator who has spent his career meticulously documenting his clinical cases photographically. He has over 85,000 photos from decades of clinical practice and has even published many of them in his textbook. In short, Dr. Schaer is a legend and a wonderful human being. We hope you enjoy these case rounds with Uncle Mikey.
This is Vice Rounds.
Okay, so the whole philosophy behind this clinical pearls comes from over time. Okay, over time, I had come across these little pearls during medicine rounds and doing ECC rounds. Even though I've looked at situations for years, it didn't strike me that this is very valuable, one simple observation. So I started to record these down, and then I turned it into a PowerPoint lecture. And the one I'm doing today is into system. Can we mute our microphone, please? One of you has your microphone on. Thank you. And I started with some patient care and some cardiopulmonary, and we're going to now talk about some drugs that we use, and then we'll go on from there. Okay, so combining metronidazole and Tagamet is a bad thing because Tagamet is a P450 inhibitor, and metronidazole is metabolized at the liver, cytochrome oxidase P450, and therefore, if you inhibit that particular enzyme, you'll allow for increased blood levels, and you might get neurotoxicity, as happened in this Roddy, where she came in several years ago, and she had a pyometra. She actually was ruptured, and she was septic, and we gave her an H2 blocker, which at that time we only had cimetidine on board. And post-operatively, this dog could not move a muscle. She just lay there in the cage. Her eyes moved, but her legs couldn't move. Her respirations were okay, thank goodness, which prompted me to go back to square one and look at the treatment sheet that I had prescribed, of course. And I noticed that the cimetidine and metronidazole were there together, and I looked up those drugs, and sure enough, I found out that the metabolism of the metronidazole would be slowed down. And it took around 2 to 3 days for her to regain enough strength where she could posture, and she went on to recover and did well. Last week, I mentioned the condition called craniomandibular osteopathy, and you remember that's the condition whereby Cairn Terriers and Scottish Terriers and West Highland Whites get that proliferative periosteal disease involving their mandibles, and it affects them at a young age, usually around 2 to 3 months of age. And here you see a little puppy that came into me in private practice. And this was already after my 7 years at the AMC, where I knew that prednisone had saved several of these dogs. And there isn't any evidence-based medicine to support this, but I've treated several dogs since. And if you do not go on to treat with prednisone, this disease can progress, going from a treatable disease to a non-treatable disease. And this typically comes in with the owner complaining the puppy is yelping when we touch its face, it's having difficulty eating, and it's just telling you basically, I have pain around my face. And you'll be able to palpate the mandibular thickening, which is the earliest sign before you start getting all that periosteal proliferation. And this little bugger was really painful. As you could see, he's all anxious and everything. And here I show you a couple extreme cases where the disease went on to progress. And here we see the mandible of this was a West Highland White. And this is why they call it lion jaw in the older literature, whereby you have that bony proliferation. You don't want it to get this far. And then if things get really screwed up, you could start getting a lot of pathology around the TMJ, and you'll fuse the temporal mandibular joint. Notice all that soft tissue swelling around that mandible, and it is intense inflammation, and that is why they are tired, are very painful. Mind you, NSAIDs will not work for these, but prednisone, I guess I pulled that one out of that black bag where Never Let Them Die Without the Benefit of the Silver Bullet comes into play. And don't forget that, please. You could see here, again, some of this proliferation along the facial bones. This was an actual case belonging to one of our students where some clinicians were treating this dog with NSAIDs, and it really wasn't cutting it. And I found out about it by happenstance, and I kind of talked to the original clinicians, and make a long story short, they were willing to give it a try with the prednisone, thank goodness. And here was the dog at presentation. Didn't want to open up his mouth, very, very painful, was starting to lose a little bit of weight. Working this dog up, you can appreciate the proliferation of the mandible. And this is after 3 weeks of prednisone. The dog just turned around doing beautifully. And what I do with these, I load them up for the first week, and then I begin a very gradual taper over 6 weeks to where I extend them to alternate day therapy for a minimum of 6 months. And then they will eventually outgrow it. So the take home on this one is to make sure that you nip this thing in the bud with an early diagnosis, begin your prednisone therapy, and I promise you, I really promise you this will work. And I could kick myself for never gathering all these cases and writing them up over the many, many years. And now if you look this up in the veterinary literature, they don't recommend prednisone, but remember prednisone for cranial mandibular osteopathy. And this condition will also affect English bulldogs, bull mastiffs. So remember, it's not just a terrier problem. Okay, to continue our little advice on drugs, here I show you a kidney at postmortem. And notice how pale it is. And this is because the dog was given aminoglycoside treatment. This could very well be, for instance, a parvovirus patient that comes in, and you want to get those aminoglycosides on board to take care of those secondary gram-negative infections. But never, ever, ever use aminoglycosides without first hydrating your patient. Give them fluids first. Get that GFR, get them urinating, and that opens the door to a much safer administration with the aminoglycoside drugs. You get into trouble with these when you give the aminoglycoside early on before you, you adequately replace their fluids. Okay, you remember in young large breed dogs, there is that condition, hypertrophic osteodystrophy. And I know, and you know, and many clinicians know that this is a very bad disease as it progresses, causing marked debilitation. And today, as in the past, they used to treat and still do treat these dogs with NSAID drugs. But to what degree they succeed will vary. So back in the 90s, there were some papers, one published in JAHA, the other published in JVMA, where some of these dogs who didn't thrive and went to necropsy had bacteria cultured from these HOD lesions. And subsequently, I said, well, why not start treating these with antibiotics? And the papers at that time also had some subsequent patients that the authors treated, and they put them on antibiotics as well. And after 7 to 10 days of antibiotics, these patients improve. And I've seen it more than once on several occasions. So even though a lot of the orthopods have never joined that frame of thought, my suggestion is, if you treat these and you're not getting anywhere with the standard approach, put them on antibiotics, covering them for gram negatives and gram positives, So make it a broad spectrum and give yourself 7 to 10 days. 7 to 10 days. And I have to say, I've treated quite a few of these over my first 40 years of medicine, or make it around 35, where they did respond. And I can't always convince clinicians to do this, but I'll leave it to you to decide whether you want to use it or not. Accept it as a clinical pearl. Okay, now let's talk about some endo take-home messages. There will be times when you have a dog that has both Cushing's disease and diabetes, and they're at home getting insulin and either trilostane or OPDDD. And then the owner's going to call you and they say the dog's not doing well, the dog's slow, sluggish, and you're going to wonder what's making it be that way. Is it due to the anti-adrenal drug, or is it due to the insulin? And this is what I've learned over the years. If the dog is weak due to hypoglycemia, historically, the owner will usually report that the appetite was still normal that day. But if their adrenals are going defunct due to lysergin overdose or trilostane overdose, their appetites will be gone, just like we have in our Cushing animals. So if it's a telephone call and the owner can't bring the dog in to get some prednisone, this is why it's essential that all of your Cushing treated dogs have some prednisone at home for these types of emergencies, where you could supplement them at, let's say, a mg per kg when they need a larger dose. And but if their appetite was pretty good that day, then you're more likely going to need some Cairo syrup. Or if you're not sure, by golly, give them a little bit of Cairo syrup and a little bit of prednisone, because you know as well as I do, a little bit of pred doesn't kill anything, and it might save a hell of a lot. So always let logic be your guide. Mikey's maxims at work. For refractory hypoglycemia, remember that drug glucagon. And you'll find that dogs coming in with insulin overdose or with a very active insulinoma, you might give them a dextrose bolus, and they might not be able to maintain normal glycemia for too long, or their hypoglycemia might be sustained. What we found over the years from a paper that was published in JAVMA several years ago was that giving them glucagon by CRI at a dose of 0.5 to 13 nanogram per kilo per minute will do very nicely to get that blood glucose up to more sustained levels. Example being, let's say on the morning of surgery, where you're going to operate an insulinoma dog and the blood glucose is wavering between 40 and 50. Start that glucagon drip, and after around an hour, you might find that the blood glucose is right where you want it, and into surgery you go. Keep these pearls with you guys. Okay, this is something to keep an eye out for when you're in the ER and you're dealing with critical care medicine. Remember this little equation. Marked hyperglycemia with minimal glycosuria will give you an oliguric anuric patient. As you can see here, we used to use empty IV bottles. Today we use plastic bags, but they were still good for urine collection. So if I have a dog with an 800 to 1000 blood glucose level, and there is no urine coming out of that system, then that dog is definitely going to be oliguric and anuric. And that conforms to why, to establish a diagnosis of hyperosmolar ketotic diabetes mellitus or hyperosmolar non-ketotic diabetes mellitus, to get to those extreme blood glucose levels, the kidneys have to be malfunctioning, because otherwise, if you had normal kidneys, the blood glucose will rarely go over 700 milligram per DL because of the spillover from the glycosuria. But when the pump's not working, when the plumbing's not working, that blood glucose goes way high. And at this point, let's say after several hours following admission, if that animal is not putting out urine after sitting there with a glucose of, let's say, 800 to 1,000, and it's still anuric, ball game's all over, because it very well should have had a nice diuresis by that point. So what option do you have? Putting an anuric hyperosmolar DKA or non-ketoacidotic patient on dialysis, that would be a tough judgment call. Remember that IV fluids alone can decrease the blood glucose by 50% or more. Showing you this particular example, this little poodle, my house officer brought the dog in the evening with a blood glucose of 736. She didn't have any backup chemistries because it was difficult. They were difficult to get years ago. We didn't have blood gas units in the ICU. And because of the dog's PDPU history, she thought it more prudent to just put the dog on LRS, saw that the dog was making urine, added potassium chloride to it, and by the next morning, the blood glucose was down to 391, all by itself without giving the dog any insulin. In the meantime, she had administered the LRS and the potassium chloride during those first 16 hours, and she avoided any iatrogenic hypokalemia that would have occurred if she would have started insulin initially when the dog was hypokalemic. So this is a little bit of guesswork when you're out there in the boonies, let's say 5 months from now, and let's say you don't have chemistries at night for some reason, but it is possible. Just remember, go ahead and rehydrate them. Add the potassium chloride to the drip once you establish that their urine is being produced. And you could start off insulin in the morning, and you'll find by just rehydrating them that you will get the blood glucose down. I've seen this work time and again. Assess the eclampsia dog for hypoglycemia. Those of you who sat through my endo course might remember this. And I remember that lesson at the AMC. The usual scenario would be, let's say a little Yorkie comes in or a poodle comes in hypocalcemic tetany. The owner carries it in, the dog is carried to the ICU, it's put on the ICU table. I put in a butterfly catheter, I take out the 10% calcium gluconate, dosing it around 1 ml per kilo. And what I do with these, I give them 1 ml quickly by IV, and then 1/2 ml every 30 seconds thereafter, until the tetany stops or until they vomit. When they vomit, that means they've gotten a little bit hypercalcemic. So what I like to do after that point, after you've corrected the hypocalcemia, I put them on the floor. I want to see them posture, I want to see them walk, I want to see them respond. And there had been a couple cases on these tiny little breeds where things weren't so good. Once I put them on the floor, they were actually weak, they were head pressing, and I figured, my gosh, here's a small breed, expends a lot of energy, was in lactation, wasn't eating that day, maybe the dog's hypoglycemic. And sure enough, the dog was hypoglycemic. I correct that with IV dextrose, 50%, 1 ml per kilo, bingo. She's off and ready to go to the races. And don't forget to give them some orphan diet, and because the puppies are gonna have to be weaned. This lady here, her name was Mona. She was the ICU tech during my internship. That's 1970 to 71. She taught me a lot of medicine. I love her. So, which means that thank goodness for our ICU techs as well. I see them teaching everybody a lot every day. It's phenomenal. Okay, here's another one. Keep an eye out for the atypical Addison. This dog looks fantastic. It's a German short hair pointer. It does not belong to Dr. Campos. And the owner's complaint on this dog was, my dog ain't birdieing right, Doc. Okay, so by birdieing, which means he wasn't performing out in the field, and but the dog came in, walked in, vital signs were okay. He was bright and alert. So I said, well, okay, I really don't see an abnormality, but let's take a look. So just to show you, we got the chemistries first, and then I did an ACTH stim. And you could see that the dog's electrolytes were normal, because I was worried about things like Addison's with the dog not doing right, but a lot of things could have caused that. And with the lights being normal, I said, geez, I just wonder. I wonder if this is another one of those atypical Addisonian weirdos. And sure enough, resting was 0.3, post-stimulation was 0.4. And in these situations, the dog really doesn't need any DOCP or Florinef. They just need lifelong maintenance of prednisone at 0.3 mg per kg per day. And some dogs even do well on pred at 0.25 mg per kg per day. But should they ever experience an emergency sometime after that, let's say hit by a car or another disease like hemorrhagic gastroenteritis is a separate disease, you're going to have to bolus them a nice big dose of prednisone because their adrenals don't have the reserve to withstand that medical stress. So do bear that in mind. So now you're going to ask me, well, do you think this dog will eventually become aldosterone depleted and therefore require DOCP? My answer to that is go on a recheck and see what happens. Let's see what happens a month from then and see what the lights are doing. If the lights stay normal, then we very likely don't need any DOCP. But then we also know that there are some Addisonian dogs who have low aldosterone levels, whose physiology can still compensate and maintain normal sodium and potassium. So more objectively, if you want to measure their aldosterone level, which you can do, and if that's low, then go ahead and put them on DOCP and prednisone. Remember the atypical Addison's disease. And then when Florinef does not work, switch them over to DOCP plus prednisone. Years ago, we used to use Florinef as a mineralocorticoid, which also had glucocorticoid activity. But some of these dogs would not normalize their sodiums well enough. And subsequently, they would hang around in the 130s. After that, after making a lot of dogs Cushingoid from giving high doses of Florinef because of that glucocorticoid activity, I had to ask myself, what am I doing? So when DOCP finally came back to the market, I said, okay, let's stop the Florinef, switch them over to DOCP and give them their prednisone supplement to that because the DOCP doesn't have any prednisolone combined with it. So today, most of your cases I know are being treated with Procortin. That's great. If you read the instructions, the bottle will say 0.5 mg per kg. No, I'm sorry, it'll say a milligram, well, it's a milligram per pound. And, but you can find that some of these dogs can do quite nicely on 1/4 of that dose and sometimes even half that dose on an every 23 to 30 day basis. So you might want to start out at that 1 milligram per pound dosage and cut back and see what happens on a subsequent recheck. Okay, as already mentioned, the combination of diabetes mellitus and oliguria will give you that very marked hyperglycemia that will be typical of the hyperosmolar non-ketotic dog. Okay, notice this urinary catheter line. I do not like it. I do not like, there's only just a little bit of urine here. So this dog can very well be oliguric or going into anuria. And when that happens, it's basically the end of the game. But don't kill them if they're oliguric at first. Give them a fluid bolus, give them their maintenance dose of fluids or double that amount and see what happens. But don't put them into fluid overload situation if they're not making urine. So that particular dog that I just showed you had chemistries that look like this. The glucose was 1,190, and as I promised you, the BUN and creatinine were elevated because these dogs went into AKI from their severe dehydration, and subsequently they weren't able to allow for glycosuria, therefore allowing for the increase in the blood glucose. And that, of course, you might get neurologic changes as well. And this dog had other things wrong. She had a metabolic acidosis as well. She was even ketones positive. So this was a hyperosmolar ketoacidotic diabetic. Look at that osmolality, 297 by calculation. And normally the osmolality is 290 to 310. And here you see the anion gap of 30, where normally it's around 12 to 15. And anytime you get an anion gap that goes over 30, I promise you, you're in pretty severe metabolic acidosis country. Look at that base deficit. Wow, sick doggy. Here's another example. This wire-haired fox terrier, 9-year-old, comes in, and its blood glucose measured at 840. And you can see the creatinine starting to go up at 2.9. But look at the urine, only 2+ glycosuria with a 800 blood glucose. What does that tell you? The normal kidney would put out a 4+ glycosuria. So what this is telling me, the kidneys are already taking a hit, and this dog's proximal renal tubule is not working right. So this is going to be a situation of continued, very, very close urine glucose monitoring, and hope that this dog could come around. The wonders of dextrose for hypoglycemia. The magic dose being 1 ml per kilo by IV push, giving you a start off point with this little Maltese puppy. The head end is on your right. And here's the puppy several minutes after it received the dextrose. But mind you that the response might not always be that immediate, because it depends on how long they have sustained their hypoglycemia. And if it's been severe to where they have even seizured, they might not recover that quickly, and it might take several hours until the mentation starts to improve. So don't give up on them, hang in there, give them lots of TLC, keep their temperatures normal, and don't overdo it with the dextrose either. Stay with that 1 ml per kilo IV push, and then put them on maintenance. But don't go giving them a blast with 50% dextrose, because it is possible for you to make them iatrogenically hyperosmolar diabetic acutely, and or hyperosmolar encephalopathy, and they can die. I've watched that happen years past. So don't let that happen. So you go with your bolus, and then you go with maintenance. Don't keep on hitting them with the bolus. If you do find a situation where, let's say, a diabetic cat or a dog received too much insulin, the owner comes home from work, and the patient is wiped out, like this little kitty cat, and it comes to your practice, and you go ahead and you see the blood glucose is around 20 milligram per DL. You give it IV dextrose at 1 ml per kilo using the 50% solution. And if 50% bothers you, you could use 25% solution, but just make sure that you're going to give twice the dose of that. So instead of 1 ml, you give 2 ml. And let's say you give your bolus and you get the blood glucose up, and the cat or the dog is still encephalopathic. What do you do from there? Well, so long as that glucose is normal, you better think of giving it some mannitol or some hypertonic saline, because with severe hypoglycemic encephalopathy, if anybody from neuro is listening, remember that cerebral edema can be one of the pathologic changes that can occur with that pseudolaminar necrosis, which is the pathological lesion that occurs in the brain from severe hypoglycemia. Okay, a condition that's going to be rare. Some of you might have heard us talking about this in ICU, and that's going to be hypothyroid myxedema. Hypothyroid myxedema. Hypothyroidism runs a spectrum of severity, where you can have mild cases, very, very subclinical. And then when you get all the way over to the right side of that curve, you might have very, very severe patients. And here's the example I give you. This particular Malamute presented to neurology for the primary complaint of weakness. And on physical examination, the dog had a non-localizing diffuse weakness compatible with a neuropathy. So neuro was going to work the dog up, and they did, and they didn't seem to see anything significant to account for the weakness. They put the dog under anesthesia for contrast studies and imaging, and what happened from there, the dog would not recover from anesthesia. The body temperature dropped to as low as 94. Respirations became very slow, and they stopped the anesthesia, but the dog still would not recover. So I happened to be passing neuro, and they asked me, did we miss anything here? And I said, oh, let me look at the record, and I'll be back, and let me go back to square one. And I did notice through the referral veterinarian's workup that the dog had a 32 pack cell volume, and the cholesterol was around 560 something. So I went back to neuro and I said, I have a funny feeling this dog's hypothyroid. And it basically was in a hypothyroid myxedema coma situation. So what we did is follow the principles for treating. Note these. Number one, you do slow rewarming. And that means room temperature. Don't put heat lamps over them. Don't wrap them up. Slow rewarming. Maybe a light sheet if it's like a cold room like our ICU, called the great freezer, you know that. And the other thing you want to do is give them levothyroxine or like Suloxone. Now, if the animal is comatose and you can't give it orally, there is a parenteral form called L-levothyroxine. We usually keep a bottle of it in our pharmacy, and you can give it IV at the same dose as you would give the oral of 0.2 mg per kg. It's also important to give them one hit of glucocorticoid because of the hypometabolism. Remember, the body's furnace turned off. That means the adrenals are sluggish. So in this time of stress, physiologic stress, they need some prednisolone as well. So we go to slow rewarming. We're going to give them the thyroid replacement. If they're conscious, go ahead and give them the Suloxone. That's fine. It will be absorbed. And give them some glucocorticoids, and then give them time. And they will recover. And this was the dog's workup. I do want to say that the PCV and the cholesterol was only 358, but to me, I read it as possible hypothyroid, and I read the dog as having hypothyroid neuropathy. And the CK can sometimes increase with these myxedema patients as well, because the creatine kinase, we used to call it creatine phosphokinase, will creep out through the muscle membrane. And the enzyme that's in the sarcoplasm will go into the circulation, just kind of seep out. And then, of course, the thyroids came back as low. And I'm going to treat for the treatable before I get these hormones back, because you might have to wait a day for the result. So when the shoe fits, you wear it and you treat for it. You'll notice I also wanted to do an ACTH stim. In this case, it went from 6.2 to 16, which is okay. And we still gave the dog its glucocorticoid. But the reason that I want those cortisols measured is because some of these cases can come in with a polyhypoendocrinopathy, which is an immune-mediated disease called Schmidt's syndrome in people, where you get autoantibodies against the adrenals and the thyroid. And the initial veterinary papers were published here in 1985. And so following all of these recommendations, this was the dog on the following day. Everything was a lot happier, and his neuropathy went away, and the anemia went away, and the lipids came down, and he was a happy camper, but it required a thyroid treatment forever. So remember these extreme cases. Okay, and on the other end of the thyroid spectrum, we see the hyperthyroid patients. And years ago, before we were doing I-131, we used to operate these patients. And if it were a bilateral thyroidectomy, the surgeons would dissect out one of the parathyroids and leave it in the cervical region, or transplant it to muscle bellies, and then the cat would recover, and it would recover no longer hyperthyroid. Maybe some of them even recover hypothyroid. But then there's always that threat of hypocalcemia, because once you do surgery on that parathyroid and mess with that parathyroid gland, it might have some ischemic change, and it might not work right away after that manipulation. It might take a few days, it might take a few weeks. In this particular cat's situation, it actually took several months for that retained parathyroid tissue to click in. So this particular cat was extremely hypocalcemic. It was 4.6 milligram per DL post-operatively. And when my flash discharged, when I took the cat's picture, it jumped toward the top of the cage and hit its head, unfortunately, because of the hyper neuroexcitability that you run into with hypocalcemia. And then we had a supplement with calcium and vitamin D analogs. So the cat wasn't quivering like your usual expected eclampsia dog. She just looked weird post-operatively. Okay, for some of you neurons, give you a few pearls. This was a bad brain trauma, and it wouldn't surprise you that this dog had ipsilateral changes on presentation, but it probably went to necropsy because of severe edema along that brainstem. Okay, don't forget thiamine deficiency. I mentioned this last week. I'm going to mention again. You're going to have a cat that comes in with a history of a normal cat food diet even. The owners don't have to profess that they've given the cat mackerel or herring, which have high levels of thiaminase. And thiaminase would destroy the endogenous thiamine. But regardless of that diet, these cats can still go into thiamine deficiency. For the first few days, they're ataxic. And then they'll stop jumping onto furniture, etc. Then they'll come in with then they'll develop mid-position or dilated pupils. And when they come in and look at you, they look like they're ketaminized. And you're going to put the Z's somewhere above the foramen magnum. In this situation, think thiamine deficiency. Think thiamine deficiency, because it's treatable. And giving these cats 50 to 100 milligrams of thiamine, IM or sub-Q, and I caution you, it does sting. They will be 50% better by day 2. Well, what happens if the thiamine is supplement in the food? Why does that cat go deficient? Because by the time food goes through processing, gets put into a can, gets pasteurized, gets stored, maybe in a warm warehouse, and then transported, that thiamine, which is heat labile, can become inactive. And that's why a, quote, balanced cat food ration can give you thiamine deficiency. Or you might see thiamine deficiency accompanying other diseases that characterize with PDPU, like chronic renal disease or a diabetic. And they come in giving you these signs on top of being diabetic. Think thiamine. And don't give it IV push, by the way, because it's very anaphylactogenic. I give you a list of the causes of rapid progressive lower motor neuron paralysis. These are the animals with hyporeflexia, and they're very weak. And I give you tick paralysis, organophosphate intoxication, botulism, polyradicular neuropathy, metronidazole intoxication. Don't forget the coral snake, of course. And when you have this combination of coral snake envenomation with hemoglobinuria from the hemolysis, only the coral snake envenomation will give you the lower motor neuron with this pigmenturia. So don't forget that. And remember, only 50% of the dogs with coral snake envenomation will actually have hemolysis. And this has to do with their sensitivity to the phospholipase A component in the venom of the coral snake. So here's our little beauty. And this would be the bad combination of neuropathy plus the pigmenturia. And some of these cases can go into AKI as well. So that's why we do put them on IV fluid maintenance, watch their urine output, keep it nice and happy. And if for any reason their BUN and creatinine starts to increase, then you start perhaps trying a little bit higher dose of your IV fluids and monitoring that kidney because it had experienced AKI. And by the way, they will require just about a week of hospitalization with IV fluids. Okay, what about coma? What causes coma? Well, the common denominator is diffuse brain involvement. Diffuse brain involvement, which can be made up with, let's say, diffuse cerebral disease. And that can occur with severe encephalitis. And we could also get coma by knocking out the reticular activating substance in the brainstem. So you knock out the brainstem from the midbrain on back in that area there, you're going to have a comatose patient. Then you can also get coma with metabolic causes. And that's why we're always wanting to do the treatable things first. Get a blood gas, look at their glucose, look at their sodiums, look at their blood ammonia, look at the medical causes of coma. Once you rule out medical causes of coma, then you start thinking of structural disease. And then you go back and you start thinking of pharmacologic disease. Did the dog or cat get into any medication at home that altered its state of consciousness? So again, a good physical examination, a good history. Please don't ever be too busy to get a good history. That's why you'll always see me around asking to get another history, and don't be surprised if you come up with new information. When you have an animal with metabolic encephalopathy, they will characteristically retain their pupillary light reflex and their oculocephalic, also known as the dow's head reflex. So you get an animal that's gorked out, but their pupils work and their eyes move like those little toy dolls. You move their head and the eyes move the opposite direction. That means that their brainstem is working. And let's hopefully find a metabolic cause to their encephalopathy. I'll never forget this story. It was from a patient of mine at the AMC, and I was working my night shift. And the owner came in with tears in her eyes saying, "I am so sad because I brought my cat to my local veterinarian to have his ears cleaned. And when I picked him up at 5 o'clock, the cat was flipping around all over the place and his eyes were moving funny directions. And the veterinarian said that it's probably best to put the cat to sleep." Whoa. So the owner didn't really like that at all, and brought the cat in, and on physical exam, the cat was grossly vestibular, and it basically was caused iatrogenically from the ear flushing. This happens, and it'll happen to you maybe, and if it does happen, then just be honest and explain it, and always walk into this situation beforehand, warning the owner that this could be one of the side effects of ear flushing. And but if it does occur, it will get better, but they might have a residual head tilt. Okay, I see your hand raised. Do you have a question? Please do.
Yeah, so I wanted to ask about the ear flushing. Obviously, hopefully it's rare, but I was wondering if there's anything we can do when we're doing ear flushes to prevent for like trauma, like always like, do you know if it happened when the cat was awake? Like if we sedated a fractious animal, would that cause less trauma, or is it just pretty much any time we're flushing, we could potentially cause it?
Okay, well, taking you back to years back, what some vet practitioners would do to clean the ears out they would use the dental cavitron, and that ear flush under pressure might damage or might cause further damage to an already damaged tympanum, and in that case, open the door to the vestibular region where the damage occurred. Even if you take all of the precautions, it can still happen. And I would just say, leave that as one of the things that might go wrong to help ruin your day, okay? Maybe it's not.
Thank you.
Okay, thanks for the question. Intoxications, okay, of course, we want to think of things like antifreeze and other things that cats and dogs can get into. Well, there used to be a TV program that was about doctors, and they had this human patient come into the ER, and it was a ethylene glycol ingestion, and they tested the person's urine under the Woods lamp to see that it glowed, and that positive test was their backdoor diagnosis to ethylene glycol. But the story behind this is the following. The antifreeze contains fluorescein, and that allows for your car mechanic to crawl under the car and see where the source of leaking is in the radiator. They use a Woods lamp type of light to see that nice greenish stain for the fluorescein. And what happens if the animal ingests the ethylene glycol, the fluorescein on the first pass through, after it's absorbed, it's absorbed through the stomach, because it's an alcohol, probably goes through the stomach, and it passes through the kidneys. The first pass GFR will perhaps register some of that fluorescein. But if the ingestion was hours ago, that test will not be positive. So don't count on that Woods lamp to give you any indication for the ingestion of ethylene glycol. You might want to do a urine set and look for the crystal urea. We used to treat these with 4-methylpyrazole, which worked very well without making the animal drunk. If we were to give them 100% ethanol, it would make them inebriated. And the 4-MP came along, and it was first marketed in Europe, and it will offset, it'll prevent the metabolism of the ethylene glycol to its metabolites, the latter which cause the intoxication, therefore allowing the ethylene glycol to pass out of the body. Well, 4-MP was fine for dogs, but we learned very quickly that damn stuff was expensive, and many owners could not afford it. And then we subsequently found out that the dose recommended for dogs couldn't be used in cats because the cat metabolized the 4-MP very quickly. So the 4-MP did not last. So the antizol, which is sold in a human medicine, it's still around, but it doesn't have a veterinary label because it was too expensive to use. So that brings us back to ethanol being the only treatment. And don't forget that vodka works. Vodka works. If you don't have pure ethanol, 100% grain alcohol, vodka works. It's 90 proof. And if you want to give it the equivalence to the ethanol, if it's 90 proof, that means it's 45% ethanol. And then if the ethanol is normally dosed at, let me try to remember, 20 ml per kilo, I would have to check on that. Then I would go ahead and give the vodka at that same dosage orally, and you will accomplish the same good as you would with 4-MP or with the pure ethanol. So I remember nights at the AMC when I was on overnight duty, and we didn't have any ethanol because it was under lock and key. In the middle of the night, I didn't have access to it, and we had to go to we had to send somebody to the overnight liquor store to get the vodka, and we would give it to the animal, and it worked as long as we get it to them before severe renal damage takes place, which means that you have to give them treatment within the first 4-hour window. Okay, another intoxication is going to be lead poisoning. And you rarely have the owner witness that the animal ingested lead, but the little puppy or the kitten could have been ingesting paint chips or wallboard during a renovation process in the home, and the animal comes in, it might have a little vomiting, and then it becomes encephalopathic, and on examination you have some tender abdomen, and you go ahead and you radiograph and you see these metallic densities in the GI tract. That is guilty until proven otherwise. That is guilty until proven otherwise that they ingested a lead-based paint or lead containing in the wallboard. We would send out a blood lead, but you're not going to get results oftentimes for 5 to 7 days. But in the meantime, we would go ahead and we would get treatment going and basically have the animal all fixed up by the time we got that blood lead back. So what do you treat lead poisoning with? It's still out there, by the way. It's still out there. When you go out to rural America or you go out to the urban America areas and you have renovations or you have barns with peeling paints, you're still going to run into it in both small and large animals. And the main drug is calcium EDTA. But it's very, very expensive, and we give that parenterally. And if the owner can afford that, we used to give them an oral drug, which is a lead chelator called penicillamine. But penicillamine makes people and animals have vomiting and diarrhea. So you got to be careful with that. So the alternative drug is DMSA, or dimercaptosuccinic acid. Dimercaptosuccinic acid is a very effective chelator of lead and some of the other heavy metals. And it's very efficacious. There have been veterinary articles that support that. And it's a derivative of what's known as British anti-lewisite, BAL, reflecting dimercaprol, and it was sold as BAL for British anti-lewisite, which goes back to its origin back in around late World War I and early World War II, when London, England was afraid that the Germans were going to drop bombs containing arsenic on London. Their scientists created the substance that would chelate the arsenic called British anti-lewisite. And they used it to treat people should they get the arsenic intoxication. Well, this translated over therapeutically to also using the chelator for lead poisoning as well. So I thought you'd like that little bit of history. Okay, we have a few more minutes and we're going to talk about the urogenital system. You've heard of pyometras, hemometras, mucometras. Well, here's a hydrometra from a cat. And this was pretty easy to palpate. This is one of those situations where I ask my student to palpate the cat by putting their hands on the outside abdominal wall, and don't squeeze hard, just push in gently, like you would be squeezing on one of those Mickey Mouses within the Mickey Mouse balloon. When you go to Disneyland, you got the Mickey within the Mickey. Now, if you want to feel that inner Mickey, you can't squeeze the outer Mickey too fast. Otherwise, you won't feel the inner Mickey. So you squeeze that, you palpate that abdominal wall very, very carefully, and your hands will feel the distended viscus. That's one of my lessons on palpation. So here's hydrometra. The hydrometra cat will not come in very, very sick. They won't come in polydipsy-polyuria. They usually come in with maybe a little bit of not eating and weight loss. and their abdomen will gradually enlarge. Don't forget to rule out the pyometra on any sick, intact female dog or cat. And verify the signalment in the record that's on the record with the owner. Verify, verify, verify. Because if the record says spayed and she's sitting on a pyo and that didn't make you think of pyo, then this dog is in trouble, serious trouble. So don't forget to think of a pyo in any intact female. And I've seen pyos in animals as young as 9 months of age. So it's not always a middle to older age situation. Never let the sun set on a pyo. And this should be corrected to really say never let it set on a sick pyo. I mean, if the dog comes in at 11 o'clock at night and it's PDPU and the appetite is still there, it could probably wait till the morning. But if it's a sicky poo, you want to operate. And notice the asymmetry in this pyo. There are all sizes and shapes of uterine distension regardless of the pathology. Whenever you get a call in the middle of the night of a male dog or cat that's straining to urinate, it's best to see it rather than to second guess it. And in the case of a female, you might want to second guess it and say, oh, it's probably cystitis, it could wait till tomorrow. But when the male has straining, there's usually a reason for it, i.e. outflow obstruction, as shown here with a prostatic carcinoma that compromised the lumen of the urethra. Now, sometimes the female dog will have urethral obstruction as well. So don't generalize too much. And if the owner's not happy, you best see the patient just to make sure. Any male dog or cat with stranguria, work them up. Oh, and I show you here that ventral vertebral body proliferation that is very typical of metastatic disease from a prostatic carcinoma. A female dog that strains to urinate can have a whole bunch of pathologies, but it can also have urethral pathology as well. When I do a rectal palpation on a normal female dog, I'm going to take you to the area of parasitology for a second. The normal urethra on rectal exam will feel like a cestode. It'll be flat. Whereas if you have an infiltrated urethra from inflammation or cancer, it'll feel like a nematode per rectal examination. And then if that is the case, under sedation, you could pass a brown rubber catheter up the urethra while somebody else has their finger in the rectum. And when they feel that the catheter is where your finger is, over that area of pathology in the urethra, the person with their finger in the rectum will compress that down a bit while you aspirate on the syringe end of that catheter. And then lo and behold, cytologically, you could get some real nice specimens. And this was a transitional cell carcinoma. At this point, do any of you have any questions on anything that we covered thus far? Okay, therefore, I think this would be a good place to stop. And I wish you a very happy day. Stay healthy, stay safe. And oh, by the way, I hope you used a glove on that finger when you did that rectal. Gross. Okay, sorry about that. Okay, we'll see you tomorrow, 9 o'clock. Take good care. Bye-bye.
Thanks again for tuning in. We hope you enjoyed these digital case rounds with Dr. Michael Schaer, and we hope everyone is staying safe out there. We'd like to extend a huge thank you to Dr. Michael Schaer for allowing us to share these rounds on the Vice Rounds platform and with you students all over the world.
Thank you.
Thank you.
You're welcome, guys. Take care. Bye-bye.